I think I want this to be as constructive as possible, because I think we've done a lot of good things, but there's a lot of things we can do better. And now's the time, as we approach hopefully the next decade and we're moving to a new relationship with the National Cancer sort of Collaborating Centre for Audits, how we can improve. So I think just first of all, coming to David, actually, you can reflect on how we started, and we had some key objectives in terms of, are we over-treating localized disease? Are we under-treating high-risk disease? What are the big picture questions, and are we missing anything at the present time?
Well, thank you. I think both of those still remain important. I think there's a paper came out from you looking at the US versus the UK, differences in practice for the high-risk men, and it seems to me there's still quite a bit of variation around the use of radical treatment for the high-risk men. So I think that remains important, particularly, I think, given the use of multimodal therapy as it comes in, with adding in novel agents as well as ablative therapies of various sorts. So I think those things remain important. And I think the point, sorry, let me just switch that off. I think the point that was made about by Joe of metastatic disease, again, the major advances that have been made in the treatment of metastatic disease are striking over the past 10 years. That's the thing that has had a big impact on me looking at the survival rate. So those are key areas. Now, there was an interest, I think the only other thing I would reflect was quite an interesting correspondence in the chat about machine learning approaches for MRI and pathology. I think that's clearly still in the research phase, but I guess auditing the use of such approaches might be worth thinking about. So I just wanted to congratulate you all. I mean, it was really exciting to set it up, and fantastic to see, the number of research fellows, the outcomes, the difference it's made, I think has been real. So congratulations to you all, I think.
Thanks, David. That's really helpful. There's obviously a lot of PROMS questions. I'm going to come to that a bit later, because I think we need 2 or 3 people involved in that discussion, because it is a key area. I'm going to come to Roger. We've mentioned about measures. We've talked about digging in to find out the reasons for things, particularly if there was variation in metastatic disease. That came up from William Cross. I think the question I have for you is, how are we feeding back to providers? I mean, what's your reflection from the hospital level? Should we be doing it in a different way? At the moment, we have our reports. Obviously, there's a website, but is this something that matters? Is this something that people are looking at every year? What are your reflections on that?
Yeah, I think so. Certainly, locally, our audit department expect a response from our MDT to the annual report, and so it is something that gets discussed, within our MDT. But this meeting clearly has been extremely valuable. This series of meetings, I think, for me personally, I find the face-to-face and verbal communication much more effective than me sitting down and reading a report.
Yeah,
but people have different learning styles, and my guess is other people will prefer the written document.
And so, just taking that forward, though, Roger, would you say that actually moving towards, if we're doing more regular reporting, more regular meetings, but maybe at smaller scale or something on a regional level, what are your thoughts? Because you're right, face to face, and maybe how easy people find it to reflect on their work, hearing other people's anecdotes and together.
Well, perhaps that's right. Perhaps a regional meeting is a way forward. Smaller meetings allow people to be maybe a bit more frank about their local services.
Okay.
And if you've got a meeting that engages the whole MDT, then I think that would be perhaps a more effective local strategy. Yeah.
No, thanks, Roger. I'm going to come to you, Noel. I think 2 things. One, how do we continue to raise awareness of the audit or audits? And I think, second of all, do you think we have enough teeth as an audit? We publish this data, but do you think it actually drives down into changing practice potentially, or it needs a bit more, I don't know, high level support in terms of implementing the findings?
Well, for me, Ajay, one of the great successes of the audit has been to highlight where there are areas where improvement is needed. And as Roger has alluded, that is important, because it's not so much improving the standards in the best centres, which are largely speaking pretty good. It's drawing in the margins where we know that practice is not so good. And I think the outlier reporting process was extremely valuable in that. And the work that you and others did in bringing together the radiotherapy reporting for the first time was instrumental in changing practice in large areas of the country. And so I think that we should continue to report locally. We should raise the profile in that way. And we should engage with regional areas. As Roger said, being frank with individual groups, I think actually, provided it's done in a sensitive way, is very valuable, because, you know, we had, I think, probably 3 effective answers to the questions we put to the outliers. One was, it's not our problem. Sorry, go and look at your data. And sometimes they were right. The other was, yes, we do have a problem, or we'll do something about it. And the other was complete failure to act on it at all. And that really falls in the lap of the local commissioning and the higher management groups within hospitals to deal with that. And I think we need to raise that.
So where does that regional power lie? Is this an alliance thing? Is this the integrated care boards? Because you're right, that probably does have more teeth in terms of that relevance and the way that the communication of quality improvement is done. I know the ODNs for radiotherapy or operational delivery networks. What are your thoughts on that?
Well, I think we need to work out the escalation process. It was quite instructive at the start of the outlier process that we had a decision to write to the head of the MDT. And then if we failed to get a response, to write to the chief executive and the medical director. And so most MDT leads answered. Those that didn't, as soon as we wrote to the chief executive and medical director, we almost invariably got an answer within a week or 2 from the MDT lead straight off. So I would just add a little teeth to the audit for those areas who are not responding. And I think we know pretty well within the audit where they are, where patients are not really being managed optimally. I think the other thing I would consider, and maybe this is a wider question you might want to pick up, is how we set the new standards, because setting the standards for what is accepted good practice really helped show us where the bar was and plot those 95% confidence limits so we could see where bad practice was taking place. And I think we need to sit down collectively to work out where our next 5-year standards are.
In terms of new standards, or actually or thinking of new questions as the technology evolves. So I think a case in point would be, for instance, the treatment of nodes. So a big thing for radiotherapy, high risk disease, I suppose also for surgery, is the treatment of the nodes.
Well, I think that a couple of things there. One is that treatment evolves, and often quite quickly, and we need to adapt. So looking at systemic treatments for metastatic disease, that's a really important area, because clearly a lot of patients are not getting what they need. But then if we look at some of the key areas, and there's a lot of traffic about MR scanning, but we have no standards for pathology. Nobody is really monitoring that, and we've got good ideas for how to do it. And I think we have very good ideas as to how we might set standards for MR scanning and reporting. And the audit is hugely valuable in that regard, I think, but it will need coordination and input from some of the people that have been adding their ideas to the chat.
Yeah, no, it's been fabulous on the chat, particularly about where we're moving with AI. I mean, Roger, David, quickly, do you want anything to add to Noel's point about where we're moving to and sort of new standards and how we stay above the curve, ahead of the curve?
Yes, I mean, one of the things that's not really been brought out is that with time the data will evolve, and that gives you the opportunity to ask new questions because some of the outcome data become mature.
Yeah,
I was just wondering about the we mentioned about treatment of lymph nodes, whether surgically or with radiation therapy in high-risk disease. I mean, do we have data on the extent of the lymphadenectomies being done, number of lymph nodes removed in high-risk cases?
Yeah, it can be patchy. No, you're right. I think we have a pretty solid indicator for well, there's some further validation work to be done in terms of lymph treatment, yes or no, but in terms of the lymphadenectomy, the scale of it and the number of lymph node yield, I think. Matt, maybe you can help us with that in terms of lymph node yields.
Yeah, I think it's possible to
margins
highlight
as well.
It's possible to highlight through HES the lymphadenectomy code, so whether they've had a lymphadenectomy. Yeah, it's very patchy in terms of the number of nodes. It's through the COSD data item, it's very poorly collected in terms of that. But certainly you can pick up who had a lymphadenectomy, but the extent of it is a bit more, yeah, not great. Although this was, I mean, I kind of stopped data analysis about 3 years ago, so things may have changed since then. But,
no, thank you, Matt. Just a couple of comments in the chat. So thank you, Peter Johnson, about actually the use of the cancer alliances and the leads potentially within that to have a bit more teeth if we've still got some concerns, and I think something we will use. And also Caroline Moore, that actually there's a lot to be said for combining internationally with other audits, whether that's across Europe or more widely internationally. We did a recent paper looking at the UK-US comparison. I just wanted to move to Julie and Jan specifically about this question around the prompts. Obviously, we've had these snapshots, 40,000 surveys, 70 to 75% response rates, which are huge, which have really both tracked quality across hospitals, but also variation across different treatment modalities which evolve. It would be good just to frame from your perspectives for something that was so successfully delivered, why there are challenges to delivering it now and what we can do, because sort of universally across the board we're saying that this is a positive and this is something the audit can and should do.
Yeah. So I'm happy just to make a start to that, Ajay. So I think, yeah, absolutely agree that the PROMS program was incredibly successful, and we saw that, as you mentioned, when we carried out the outlier process, for example. So for example, the indicators that were on the basis of the clinical data quite often would be challenged, but for the data, the indicators that were on the basis of the validated instruments within the PROMS, I think it was that was sort of from the word of the mouth of the patients using validated instruments. They weren't challenged in the same way. I think they were very much accepted. But I think it's important to say that even though it was a fantastic initiative, and within the team, we'd be absolutely delighted to continue, the prostate cancer audit is the only one of the national cancer audits that has been fortunate enough to have funding to carry out the PROMS survey. And there isn't, within the short term, that isn't within the scope of work, I would say. But that doesn't mean that we can't look, and I know we've mentioned this within the team, to look for potentially additional sources of funding to enable us to carry out a further round of the patient survey.
I'm thinking with Chiara and Peter online, whether that's something where we can knock heads to see, because we have the centralized resource. We saw the 7 data sets that are feeding directly into the National Prostate Cancer Audit. We added PROMS, we did it robustly, and it also provided information as to the quality of care. It, to some degree, is a no-brainer, but yes, it is important. And also, I think Declan made a very good point about the cost of doing PROMS at the individual centre level, because many people are trying to start it, but actually trying to implement it longer term is hard. Jan, sorry.
Yeah, no, I want to highlight what Julie said, but I want to take one step further. I think it's not additional information. I think it's key information. And looking at all cancer audits as if they need the same thing, I don't think that's true. For instance, prostate cancer treatment is especially an audit where the first concern is, for a while, the toxicity that the treatment itself provides, especially in an area where we rapidly start to change our thinking about who needs treatment and who doesn't. So that in some cases, and maybe still in quite a lot of cases, the treatment may not have any impact on a patient's cancer outcome. And the only thing that's important is a toxicity. So patients are interested, highly interested observers, 75% response rate, and I think it's slightly higher even than that.
and at the same time impartial. They don't have any interest in making their hospital look better than it is, or making one treatment modality better than it is. So I think we really need that. Do we need that on an ongoing basis? Maybe not. Do we need that regularly for particular periods of time long enough to capture a number of patients that allow meaningful comparisons between providers? I think definitely. The second thing is not only the patient-reported outcome measures, I think is important, but also patient experience. Is a lot of debate about to what extent patients get the support outside the radiotherapy and the surgery that they require to, for instance, deal with incontinence, sexual function problems. And we the audit has already established there is also concern, especially in terms of deficiencies in provision of those type of services across the country. Simply asking the patients, which we did, also demonstrated within our survey that kind of monitoring and feeding that information back, I think, would also allow us to focus on the side of cancer services provision, which I think you in a meeting, short meeting like this, you sometimes underexpose a bit. It's the kind of the service and support men get from the time that they had their radical treatment and they had to deal with the consequences of that.
Ajay, I wonder.
And can I say one more thing?
Okay.
It's a national patient survey like we did is not expensive. It costs money, but it is not millions and millions of pounds. So basically, in the greater scheme of things and the impact that it has, I think there need to be a conversation with us, charities, funders, but maybe also with the kind of NHS commissioners, to what extent that can be included.
Yeah, and just following on that from that, Chiara makes a very good point. You know, you uncover a lot of these disparities, both in terms of whether functional outcomes are being measured, toxicities, differences in survival, but do we have the resource to then manage that? But I think we have to highlight the need so that we can actually provision for it effectively and try and deal with many of these inequalities. Noel, you were going to say something, sorry.
Yes, I was just going to add a little and develop Jan's point further, because what we have is an internationally leading data set. We have something like 40 to 50,000 cases annually since 2013, and the capacity to link that to hospital episode statistics. So not only can we get information from patients, we can look down the line to see what effect the treatments have had in relation to readmissions. A good example being the nephrostomy insertion project that we have, but we could also look at the long-term effects of chemotherapy. We are very well placed to look at the effects of surveillance, who fails, what the effect of that is, what treatments they have, and so on. And the wider question, because there's such a detailed data set of how we make that more accessible to the talent that might be available to research it. And I'm talking about putting research fellows in, grant applications alongside it, because it all takes manpower. Because it's there to be used, and if we don't use it, well, it rather wastes a golden opportunity at a European and world level, I think.
I think it adds to Caroline's point as well about having the potential to be a sort of international powerhouse in leading the way in comparative effectiveness research, quality improvement, etc., through the rich data sets we had. So I think there is definitely a piece to be looked at within that. Matt, if I could come to you, and then one more question, and then sadly we have to end. But Matt, you had a point to make. Sorry, just on.
Mic's on now. Yeah, just on the point of proms. So presumably, I was involved with the proms a few years ago when they were postal proms. So if the problem is cost of getting funding for this sort of thing, would there be a move to going electronic? Because presumably they've got a postal address that things are being sent to at the same time. If there's an email address that they're submitting at the same time that they submit their address, then presumably that would be a much easier, lower cost way of collecting proms longer term. So that's just a query of mine, whether that can be fed back to the people that run the proms.
Yeah, no, well, I think it's a good point, and you know the electronic means do have their own governance factors which are quite tricky. So I know at the local level we've struggled with that, and in the proms pilots we've done, we find that actually only sort of 60% responded per se, and those who don't respond tend to be the ones that we end up missing out on. So I think, yeah, the different things of getting useful information, but then are we hearing from the voices that normally come forward anyway? And anything that can reduce that access barrier, I think, very important. We've got final bit, and just actually maybe if David and Roger could reflect on this, and anyone else, is around PSMA PET. Lots of questions as to its appropriate utilization. There's obviously EAU guidelines, use in high-risk disease. Should it change our management? Some places are doing it, some places are not doing it. Where does this stand as an element of good or bad performance, or how we can monitor what is evolving as being a standard of care? Thoughts?
I just think just very briefly, I mean, the way that we are able now and in the future to detect low burden metastatic disease is going to be really important. I mean, I'm always struck by the very long-term outcome data that came from the Swedish randomized trial, where you saw a steady rise in death from prostate cancer going 10, 15 years. And the question, and of course, that's likely to be a failure of immune surveillance on people with very low volume disease. So I think the more that we pick up a very low burden of metastatic disease, should it alter the way we treat the local disease, I think is an open question, because appropriate trials will need to be devised to stratify patients for that level of metastatic disease as we get more sophisticated, picking up whether it's circulating DNA or whatever. It's going to change the way we look at the disease completely, I think.
Thank you, Roger. Final thoughts?
Yeah, so availability is a major issue. We have quite a limited capacity of PSMA PET, but like many new tests, MRI's got some of the same problems. We're shifting the goalposts, and what we don't know is what the outcomes are for patients with or without a positive PSMA PET. And it's very similar to MRI with a diagnosis of T3 on MRI, but a normal rectal examination. We have no idea what the outcomes of those patients are, whether they have treatment, whatever their treatment plan.
Yeah, no, thank you for that, Roger. I think this is a conversation that will continue and is important, I think, reflective of what information in a granular perspective we can get from the radiology data set and the reports, because we don't get the full reports at the present time. Okay, well, thank you very much. Also, there's been fantastic comments, Jonathan, as well, just sending that report. Thank you very much for that.